This is actually a story. So I'll tell you about a research quality improvement benchmarking network that we've developed, but I'll give you some hints along the way, not just about the data that we've begun to publish and how that relates to benchmarking, and I'll show you some of those studies in a few minutes, but I also want to give you a sense of how we got there. Because although I've had many hats in my career, early on I thought I was going to be a medical anthropologist. I went to graduate school for a while. And so I'm really interested in cultures and cultures of medicine and how you begin to educate and change those cultures in ways that we think are helpful and productive. And I'm really interested in how difficult sometimes it can be to get people thinking in new ways. So I'll tell you a story along the way that begins to illuminate some of that. So going back about 2 years ago now, a small group of us, some of whom are probably names you know, people like 𝐃𝐓𝐈𝐎𝐍𝐿𝐒, Joan Tino, Laura Hansen, and a few others, got together and we really began to think that we needed to do a better job at doing research and clinically practical comparative effectiveness research in hospice. We needed to get better at measuring outcomes, and we really needed to get better at incorporating research into practice in hospice. And a few words of background are probably useful. In hospice in the United States, it's different in many ways than hospice in the UK. When I talk about hospice in the United States, we're talking about hospice organizations, so there are about 3,500 hospice organizations around the country. Those hospices provide care in patients' homes, in nursing homes, in hospitals, and in hospice units. I know often you talk about hospice here as hospice inpatient units. When I talk about hospice, it's care that's delivered in all of those settings. The other thing to know about the hospice world in the United States is that patients come to hospice very, very late. So our median length of stay in hospice nationwide in the US is now about 17 or 18 days. About a third of our patients are referred in the last week of life and about 10% in the last 24 hours of life. Very, very different, I think, than the experience here. And I'm giving you those numbers up front to make you realize how difficult it is to do research in the US hospice setting. We don't take care of patients very long. We take care of patients very, very late. Even measuring basic outcomes for those patients that we take care of is very, very difficult. Even getting pain scores for patients who referred in the last 24 hours of life can be difficult because many patients can't respond to pain scales. And yet Joan and Kathy and Laura and I realized that we really needed to do that. Hospice in the United States takes care of about 1.6 million patients a year, but we don't really have good evidence to guide that care, and we really don't know how well hospices are doing in providing care. So that, in a nutshell, was what led us to think about trying to develop a hospice quality benchmarking network. And one of the first things we did was to go to CEOs, executive officers who run and manage hospices, and we pitched them this idea of developing a research network that would do research, that would provide them with quality and outcome data, similar in many ways to what you just heard about with 𝐃𝐘. So that was our sales pitch for them, and they were interested. This is some snippets from interviews we did with about 25 of these hospice leaders. And they told us, yes, we'd be willing to participate in this, but this is what we want. I won't read you through this list, but it gives you a sense, I think, of how demanding probably isn't the right word, but they had very, very strong opinions about what sort of research they wanted to be involved in, what they would be willing to do, what they'd be willing to contribute, and really what they wanted out of that research network. And the last point, in a way, is probably the most important to me, and not really surprising, but it was surprising to me to hear this so clearly from so many people. And it was essentially, yes, we'd be willing to contribute our data for research. We're very interested in advancing the science of hospice care, but we're not willing to put any additional effort into research. What we really want is research that will bounce back to us. It's fine if you want to publish papers, but what we really want to know is how well we're doing and how we could do better. If you don't build a research network that tells us on a day-to-day basis how we're doing and how we could do better, then that research doesn't help us, because we don't read the New England Journal, we don't read Lancet, we read the reports that come across our desk. And granted, this is just the executive officers. So this isn't the chief medical officers, of which I'm one. It's not the frontline providers, the physicians and nurses. These are the financial people. But it's the financial people who are going to say, yeah, we'll contribute data to this network, and we'll make sure that our tech people get the data and our software people contribute the data, and we'll make sure that this happens. So if they're not on board, we don't have a research network. So we really we realized early on, to develop a research network that hit that last point. And we knew that if we didn't hit that last point, if we didn't give these executive officers meaningful data, we weren't going to have a research network. The story for the chief medical officers and the nurses and physicians and social workers and chaplains was a little bit different. And the story that resonated with them was a story that I told yesterday at the Institute, so this will be a repeat for a few of you. But Perelman was a writer, a chemist, a Holocaust survivor. And in one of his memoirs, he tells a great story of going to work in a paint factory in Italy after World War II, and being a chemist and having the opportunity to work in a paint factory. For him, who was very, very smart, very, very curious, was a wonderful life opportunity. You wouldn't think that working in a paint factory would be good, but he really looked forward to this because he thought this is a chance to put his knowledge of chemistry to work and to learn. This was a new field of inquiry for him. That was the kind of mind that he had. And so he was looking forward to the chance to put his chemistry skills to work in a paint factory and to learn along the way. But he was disappointed because every time he would ask, because he was intellectual and curious, every time he would ask, well, why do you do something this way or that way? Or why do you need to boil the paint for 10 minutes at this stage, but not longer? The answer he got time and time again, as he tells in his memoir, is some variant of, well, that's the way we've always done it. Or that's just the way we do it here. Don't ask questions, just do as you're told. And so you can imagine for somebody who's intellectual and curious and intellectually motivated like Primo Levi, that didn't fly. And so after a week, he quit and went to work somewhere else. That's really what he was hoping for, and that's what he didn't get. And I tell the story to my hospice colleagues in the United States and some of my palliative care colleagues around the world, and I often get nods because what they tell me is, and what I observe in my practice, at least in the hospice world in the United States, this actually holds pretty true. We do a lot of things in hospice, not because the evidence tells us to, or not because we've looked very carefully at outcomes, we've refined our practices, and we've determined based on evidence that we've gathered that this is the right way to do it, but we do things because that's the way we've always done it. Not always, certainly, but I think in the hospice world in the United States, in the palliative care world in the United States, I won't speak for the UK or for the world, but at least for us, this is a reason, a rationale, a justification for doing what we do far more than it should be. So this is where I'd like to take you in the next half an hour or so. I'll give you a sense of the network that we've created. I'll give you two benchmarking examples that we've been working on. And I'll say on the outset that of these two examples, there's one that's fairly straightforward. I've had a chance to think through a lot, and that's the one related to pain management. The other, I just started working on about a week ago, and I turned these slides in knowing that I had the data. I mean, the data are the data, and I've done the analysis, but I haven't really thought conceptually about what that means. And I wanted to present both to you, partly to be honest, that it's not like we know all the answers, although I'm from the United States and many of my colleagues there claim to have all of the answers. We don't, but also to give you a sense that often in benchmarking and quality reporting, I've found you really need to go to the table with the data you have, not necessarily with the data you wish you had. And so I'm coming to you with both, something that I'm pretty confident of and I understand, and then something else that frankly I could use some help with. And then I'll introduce the notion of a learning healthcare system, which is what we're trying to create with Choice. So this is the mission that we came up with from Choice. And again, back to the story a little bit, this wasn't really my mission as a researcher. This is what we heard from a total of about 100 CEOs and nurses, chaplains, social workers, physicians from a lot of hospices that were thinking about joining the Choice network. Safe, effective, and efficient hospice care. What does that look like? How do we deliver it? And how do we know whether we're delivering it? That's really what this group wanted to focus on. So initially, as we started putting this together, we identified 3 hospices. They're the ones that are highlighted. Suncoast is in Florida, Grace is in Wisconsin, Hospice and Community Care is in Pennsylvania. Those were our 3 pilot sites. They take care of a total of about 4,000 patients on average every day. And then over the course of the next year or so, we added some of these other hospices on board. So it really was a gradual process. We got a couple of hospices on board. We began to fine-tune the process of collecting data. And I'll tell you more about that in a second. But we really wanted to pilot it with a small group first. The data set we're working with now, and I'll tell you in a little bit about how we got it, but this sort of sets the stage. Those 14 hospices, which comprise about 160,000 patients, 5 years worth of data, distributed more or less throughout the United States, although there's certainly some regions we're missing. Those hospices typically take care of somewhere between 200 and 2,000 patients per day. So where are we getting these data? And this is maybe one of the most important slides I'll show you. It's also, unfortunately, the most complex, but I'll talk you through it briefly. What we do is the University of Pennsylvania, where I work, we partner with Suncoast Solutions, which is a maker of hospice electronic medical records software. And that was really the best idea we could come up with for the fundamental question of how do you collect data from multiple hospices all around the country in a way that's simple, that's easy, that doesn't create additional burdens for staff, which is a challenge. I mean, it's a challenge all of you who are interested in quality measurement, research, reporting face. This is not something that's unique to me, certainly not unique to hospice. How do you get busy clinicians to enter data? If you have something like 𝐃𝐘, which is truly amazing, and you can convince providers to enter the data for clinical purposes, that's a huge uphill battle, and so I'm really impressed at what Australia has managed to accomplish. But we're trying to reinvent that in a slightly different way, in a smaller scale, but it's more ambitious in a way because we try to pull the data out of this electronic medical record system. So there are about 150 hospices in the country that take care of about 300,000 patients a day over the course of a year. And we've partnered with this company, Suncoast Solutions, to work with them to figure out how to pull data out of these hospice software programs. And the rationale for using one hospice company, which may be obvious, but I'll explain it briefly anyway, is that if you work with one hospice company, which was our goal, you have a better sense of where those data live. And you can imagine pulling some of these data elements out of multiple electronic medical record systems, or to make matters worse, if you wanted to try to collect these data from hospices that don't use an electronic medical record system, it becomes really, really challenging. So our thought was, if we could partner with a company that makes electronic medical record software, if we could work with them to figure out where these various data elements are, things like age and gender and insurance and visits by which discipline, social worker, chaplain, how long did those visits last, pain scores, other variables. If we could figure out with Suncoast Solutions where these various data elements live in their software, we'd have a much better shot at collecting them, not just for 1 or 2 hospices, but for more than 100. Ultimately, I would love to expand this to software companies beyond Suncoast, but this was our initial thought. And so what we do broadly is to work with Suncoast Solutions to pull data elements, some of which I've listed for you, others of which I'll walk through as we talk about specific research projects, but to pull these data elements from the electronic medical record systems. So Suncoast Solutions and our research team will go in with the hospice's permission, obviously. We'll pull out data elements on a quarterly basis, updating. We'll collapse those data into a single file. We'll strip out direct identifiers, names, medical record numbers, addresses, and so on. We'll replace those with indirect identifiers, which is basically a code that identifies a patient with an arbitrary number and with a couple of letters designating that hospice. And then we transport those data securely to the University of Pennsylvania for analysis. And I'll tell you a little bit later what we do with those data. But the reason we did that is because I don't want on our secure server, although it's a secure server, I don't want names, addresses, certainly social security numbers floating around for security purposes. But we need some form of identification, so if there are problems with one patient's data, particularly if they're trends, these 4 patients, these 10 patients seem to be missing pain data. I want to be able to identify those patients in some meaningful way to go back to the hospice and say, could you look these up? Are the data missing? Are we pulling data in the wrong ways from the wrong places? And so the last thing I'll say about this slide is that we need, therefore, some linking code set that connects the arbitrary codes that I have with that patient's medical record number. And that raises the problem of where you keep those codes. Like, I don't want to keep those codes for confidentiality reasons. And so we arranged a solution that each hospice keeps its own set of linking codes. So the only way I could figure out that patient 1, 2, 3, 4 comes from this hospice and has this name and this medical record number is if I get access to that linking code file that sits in that hospice server. I'm going to give you a little bit more detail probably than you want or need, only because it took us a long time, relatively speaking, to figure out that as a solution, but also to make it clear that this was really, really important to the hospices that were contributing data. They weren't worried about a lot of things. They weren't worried about what happened to the data after I got it. They weren't really worried so much about what I would publish or what I would describe. They were really worried about confidentiality. And so we had to take, I think, probably more steps that were actually needed to reassure them about confidentiality. Not because it's consistent with the HIPAA privacy rules in the United States, but it was their price of admission. And I won't give you a lot of examples, but there are other things that we wound up doing in creating this network that weren't necessary, certainly weren't absolutely necessary, but we did to make people feel more comfortable. So there really was a lot of that hand-holding, I think more than I had anticipated. So we've done a series of projects so far. I won't walk you through this list, but to give you a range of some of the things we've done, we've tried to predict the use of inpatient care near the end of life. We've tried to figure out whether different levels of care, the third one down, predict the use of inpatient care, so do more visits at home, help people to stay at home, do higher levels of care, meaning putting a nurse in a home consistently 24 hours a day. Does that help people who want to stay at home, and so on. So we've tried to do a number of studies with a couple of goals in mind, partly to get a sense of what good care looks like, partly to get a sense of what variables affect these sorts of outcomes, like when a patient wants to die at home, is she or he actually able to die at home, which is one of the outcomes we focused on. But also to get a sense of how far we could push this data. I was really curious about the quality of data, the reliability of data, and trying to figure out whether we could actually ask questions that would have enough legitimacy to get published in mainstream journals. And that was something we really felt we needed to do in terms of taking the next step and moving into the realm of quality improvement and benchmarking. If we couldn't get our methods and the results that we found published in mainstream journals, then I wasn't really confident we could actually go back to hospices and ask them to begin to implement the research findings that we produced. We'll talk a little bit later about a circle of going from research findings to implementation and feedback in a learning healthcare system. But somewhere in there, I realized we really need, as researchers, those of us who are, really need to publish, because that's what gives us legitimacy, not for every single project, but that's what gives us legitimacy for the frontline providers. When we come to them and say, we have good evidence that you should do this, or this, they really want some proof of legitimacy to back that up. There are 2 that are highlighted here, and these are the benchmarking ideas that I wanted to spend a little bit more time talking on. So these are studies that we did that began to identify patient characteristics that are associated with outcomes, although it's not strictly true in terms of outcomes. But one project was trying to figure out which patient characteristics predict whether patients get more visits from nurses, chaplains, social workers in the home care setting. And the second is related to what factors predict who will have adequate pain management. That's the O209 measure, which I'll describe in a minute. But these were 2 studies that then led to benchmarking, in the hope that I hope many of these studies will also lead to benchmarking in the next 6 months. But before I get to those, just some broad points. We've learned a couple of things along the way. And these are learnings for me because I was going into this expecting that we might not be successful. I mean, we had never tried to pull this much data from this many hospices with this amount of detail before. I'd had some experience in the VA, but our veterans health system in the United States, But that was much easier in a way because we were using electronic medical records, but also a lot of staff to pull data. But this is the first time that we are really relying heavily on our ability to pull from electronic medical records. And I think more importantly, we're relying on frontline providers to actually enter those data. So we're pulling and we're hoping those data are there, which is something we can talk about later. But probably the most important finding, and this is what came out of the two studies I alluded to, which I'll take you through in more detail, is that it looks like there are, for many of the things we focus on in our hospice world in the United States, like how many visits are our nurses doing, and what are our patients' pain scores. It turns out, not surprisingly, that there are some patient characteristics that affect how well we're doing. So it's not just a matter of what our nurses are doing, or what our schedulers are doing, or what our physicians are doing in terms of medication orders for pain, but there are some things, so it's not just what we bring to the patient, but some of these outcomes, some of these measures are affected by what the patient brings to us. And so my pitch to the chief executive officers and to some of our physicians is, if we're going to have meaningful benchmarks, like truly meaningful, if you want to know how well you're doing relative to another hospice or relative to another 100 hospices, it's not enough just to report pain scores. We really need to know how your patients compare with other patients, specifically with respect to those patient characteristics that make a difference. And I'll walk you through those in a couple of details. So let me give you a couple of examples. My chief financial officer, the two benchmarking examples, there's one that I think I've had a chance to think about, figure out what it means, and to conceptualize what the next steps are. The other is, I think, much more preliminary. I've been looking at these data really carefully over the last week or so, mostly on the red eye from Philadelphia to Heathrow 2 nights ago. So these are still fresh. So this is the fresh one. This is the one that I'm still trying to think through. But part of our strategy in running this research network is to share data before we've had a chance to be sure exactly what everything means. And there is a lot of dialogue. So in a way, I'm kind of playing out for you the kind of dialogue that I expect to have with some of our hospices over the next couple of weeks. I'll show them the data, I'll tell them what I think it might mean, and then they'll tell me what they think it means, and then we'll figure out how to work that into benchmarking. So this is in the form of a story. So my chief financial officer, who comes from a hospice in New York, often tells us, to a degree that's really quite annoying, frankly, how they used to do it at his hospice. And there's a limit to how many times you can hear those stories. 30 or 40 is about my limit, and he's up in the low 300s at this point. But he loves to say the way they used to do it. So one of the things he always says is, at the hospice that I used to work for, nurses did 5 visits a day, but our nurses on average only do about 4 visits a day. We need to be more efficient. To which I would usually respond, whenever he says this, which is often, is that true? Are we really less efficient? Or are we just taking care of different patients? So I'll get into some specifics on the next slide, but I just wanted to set that up because I'm not really sure the specifics I'm going to show you match this because I haven't really thought through this. But hopefully the principle at least is clear, that if you're saying that this hospice in upstate New York does this many visits and we have a different frequency, is it possible that we have different patients? Maybe their patients need more visits. Maybe our nurses take longer with our patients because they're more complicated, or some combination. That's the piece I haven't really thought through. But hopefully I've convinced you that it's not appropriate just to compare averages and aggregates because those patient populations could be very different. The other thing I'll tell you, just by way of background, is that his hospice was in a rural area in upstate New York, much less severe illnesses, patients referred much earlier, but longer driving times, and so forth. I work for a hospice affiliated with an academic medical center. About half of our patients are referred in the last week of life, a third are referred in the last 48 hours of life. So very, very different levels of acuity. Reasonable, I think, to think that those are different. So this is a study that we published in the Journal of Palliative Medicine. I think both of these are from JPN, actually, to try to evaluate that. And I won't spin you through methods. I'm happy to talk offline, also happy to show these papers. But we used a mixed effects model in which the number of visits patients got in the first week of hospice care was the outcome. And we summed nursing, physician, chaplain, social worker, home health aide visits. So all visits combined. We could unpack those, but for this analysis, we used all combined. We used a mixed effects model in which the random effect was the hospice, because there were multiple hospices involved in this study. I think we used 12 for the study. And then we looked for predictors of visits. So what patient characteristics at the time of hospice enrollment predict how many visits those patients are going to get. And we came up with, not surprisingly, a bunch of variables. And I didn't want to show you the list, but I want to show you the list in terms of how this actually can contribute to benchmarking. Again, this is where my brain gets a little bit confused because I haven't really thought through this. But think about this as one way, and then come up with your own models along the way, because I don't think this is it, actually. But you could imagine, for instance, one conversation going, well, Hospice A has more visits per day on average than Hospice B, and these data are actually taken from 2 of the hospices in that 12 that I showed you. Hospice B seems to be less efficient, but even though Hospice A has more visits, those patients have a variety of characteristics that are in a multivariable mixed effects model are associated with visits. And what you get then, if you take those and you adjust them, is that Hospice A's visit frequency is actually lower. So I'm actually going to spin through this because, again, I haven't really thought through this. But the main point there is if you compare visit frequencies or other outcomes, but don't take into account some of these variables that are associated with whatever outcome you're interested in, you're going to get results that are either not as large as you think or potentially even flipped, and you could flip relationships. So think about that. This example actually is more clear because I've had some more time to think about it. At the hospice I consult for, this is my chief executive officer now, the average comfortable dying score is 85%. Just out of curiosity, if anybody is familiar with the comfortable dying measure? Good, I'm so glad this hasn't made it across the pond. This is, it's the worst measure ever, and it's a clear example of what happens when a payer like Medicare decides to start measuring quality. So the quick summary is, it's the proportion of patients whose pain makes them uncomfortable at the time of hospice enrollment, whose pain is controlled to a comfortable level within 48 hours. So the denominator is patients whose pain is making them uncomfortable at time 0, and the numerator is the proportion of patients whose pain is controlled to a comfortable level. So higher numbers are better. A lot of problems with this. Actually, Medicare initiated it and then dropped it after a year because they realized it was so bad. The big problem, I'll allude to quickly, is that if somebody becomes unable to respond to that second assessment at 48 hours, right, time 0 and then 48 hours, that counts against the hospice. So if somebody becomes sick, if they become so sick they're about to die, if they're unable to respond to questions about pain, that counts as inadequate pain management, which many of us pointed out was going to be a problem given short lengths of stay, but Medicare didn't listen. Finally, they listened, and they dropped that measure. We used a slightly variant version of this for this paper that excludes those from the numerator and the denominator. Right, is that clear? So this is the proportion of patients who had uncomfortable pain at admission, whose pain was controlled to a comfortable level within 48 hours. Why it's called the comfortable dying measure, I have no idea, because it has absolutely nothing to do with dying, but there you go. So you could ask the same question as I do of my chief executive officer. So the hospice I consult for, the average dying score, comfortable dying score is 85%. Ours at our hospice is probably running these days in the high 60% range. And so her argument is, well, we need to do better. We need to do better at least than we're doing, and we need to do as well as this other hospice. To which the rejoinder is the same point that I made earlier. Well, is that really true? How do we know that unless we know that our patients are the same as those patients? It may be that our patients have characteristics that make their pain harder to manage. It may not be. I mean, we may actually have a real problem, but until you compare apples to apples, we really don't know. And so that was what motivated, Lauren Kelly was a medical student who was working with me one summer ago. And that's what led us to do an analysis of these comfortable dying 0209 scores in the hospices in the network. And we did pretty much what we did for the visit study that I showed you before. We looked at those scores. We tried to figure out which characteristics in a mixed effects model predicted whether hospices were able to meet that score on a patient level. And so this plays out pretty much in the same way. So imagine Hospice A has worse scores on average than Hospice B does. But you could imagine a scenario, and this is again 2 hospices within the network. You could imagine a scenario in which even though Hospice A has worse scores, Hospice A might actually be doing better if you account for some of these differences. And so all of these scores, all of these variables are things that are associated with adequacy of pain management on that measure. So Hospice A has worse scores, but they have the deck stacked against them. Their patients are younger patients in a mixed effects model had lower scores, less likely to have spouse caregivers. So people with children as their primary caregivers tend to do worse on the score, more likely to have cancer and a couple of other variables as well. I didn't take you through all the variables. Those aren't nearly as important as the general principle that, as I said before, unless we figure out what patient characteristics are associated with the outcomes that we want to measure, whether those are hard outcomes like pain management or sort of softer outcomes, more process measures like visits, although visits are outcomes if you're a financial person, then we're not measuring appropriately. And so when you adjust for those, not only is Hospice A as good as Hospice B, but the results actually flip. And so in talking to CEOs and providers, I've tried to make this argument that just presenting aggregate results is not going to be helpful and may actually be misleading. And this is particularly useful to me because if I had taken my CEO at her word, I probably would have called up the chief medical officer at this other hospice and said, well, what are you doing well? And whatever that hospice is doing is some set of practices that I would want to import into my practice, rightly or wrongly. And so imagine a situation in which Hospice A went to Hospice B and said, well, what are you guys doing? You clearly are doing something right that we're not, but when you do the adjusted analysis, actually, information, best practices should be flowing the other way. But you don't know that unless you have patient-level data. And just parenthetically, before we begin to wrap up, I guess I was surprised by this. I figured that patient characteristics would be important. I mean, I'm enough of a health services researcher to know that. But I didn't realize just how important that they are. Granted, they're more important for some variables than for others. And we may just have hit a couple of important outcomes for which these sorts of patient characteristics are very important, and other things they don't matter so much. We've done a lot of work with family satisfaction. Turns out the case mix doesn't matter so much with family satisfaction. At least that's my take on our research and the literature. I could be wrong. But compared to my experience with family satisfaction scores, these differences really are fairly large. So this is a roadmap of where we've been and where I hope we're going. We really, as I've showed you, focused on research, focused on trying to get the legitimacy that goes with peer-reviewed publications. We're getting into benchmarking now. Where I'd really like to go and where I'd urge us all as a community to think about going is to think about decision support. So particularly as more of us start using electronic medical records, there's an enormous opportunity, I think, not just to do research, to identify best practices, to feed those back to providers, which is great and important, but also to take the next step and to begin to embed some of those best practices in electronic medical record systems. So you're not really not only relying on teaching a physician that this is really the best way to develop a care plan for a patient who wants to remain at home, for instance, but beginning to put flags and nudges and forcing functions into electronic medical record software to provide additional tools. That really closes the loop, and we're probably about a year away from being able to do that with choice. But I think some of you who work with electronic medical record software might actually be closer. I know Bob Dunlop, who's here in the UK, is nationally recognized, internationally recognized for some of his work, and we're actually working with him to develop some of his tools and to put them into Suncoast Solutions and others as well. But that's where I'd love to go. So we began this with a small group of 12 hospices. We're now in the process of rolling it out to 50 hospices by the end of the year with the goal of reaching 150. We already have, somebody just emailed me this morning, we have 84 hospices signed up that want to submit data. We just put that call out about 3 weeks ago. So I'm pretty confident if we have the technical background to do it, we can hit that mark certainly by the end of the year. And then hopefully 150 by the end of next year. These are some of the priorities that we're focusing on. I won't walk through the list individually. The hospice items, though, just briefly, are the new Medicare mandated set of data that all hospices need to collect. And they include some things like pain management, other things like whether a spiritual assessment was done, whether an assessment of dyspnea, shortness of breath was done, and a few others. The advantage of those is that they're mandated by Medicare, so hospices need to collect them for all patients or face a decrease in payment. So we're fairly confident that we're going to be able to find those. And we've tried to drill down, I think, in 8 hospices so far, and completeness rates are greater than 95%. And it's still pretty early. The requirement just came out a couple of months ago. As well as some of the other things. We've tried to develop a mix of things that are important to frontline clinicians, like hospice items like pain management, but also things like cost per day, emergency room visits, revocation rate, which is the proportion of patients who decide to withdraw from hospice. And this list, ultimately, I think will have a little bit of something for everyone. We want things on this list that will appeal to chief executive officers, things that on this list that will appeal to physicians and nurses, and everything in between. That, at least, is our goal. Briefly, the way this is going to work, and I'll spin you through this very, very briefly, but we submit the data. Each individual hospice submits the data. We de-identify the data. We calculate means, medians, percentiles, both for the entire group and for subsets. So if a hospice wants to know not just how well they're doing with respect to pain management, but how well are we doing with respect to pain management compared to other hospices that are our size, that are also rural with long driving distances, and how well specifically are we doing compared to other hospices with similar characteristics for patients with cancer, or for those with dementia, or for those after a stroke. People will be able to subset those data so they can develop their own individual comparisons, and we'll develop those subsets based on some of the analysis we've done, like what I've showed you, so we know what characteristics are associated with better pain management or more visits. We can define those subsets in an evidence-based way. And our model, which again we've developed based on our work with our focus group of about 30 people representing some of our hospices, is that the reporting function will actually be built into the electronic medical record software. And this was, I think, one of the last important points I'll leave you with. That was really important. People wanted to be able to pull these reports whenever they wanted. They didn't really care how often some of the benchmarks were updated, when those 50th or 90th percentiles were updated, or when the subgroups were created or revised. But they really wanted at any one point in time to know how well they were doing. And so we're in the process of building that into the electronic medical record software. So at any one point in time, a physician could know exactly how well her patients were doing with respect to pain management relative to a benchmark. That benchmark may be 2 or 3 months old, but people told us they really want real-time data. And that's been, as you can imagine, a huge amount of work, and we've really bent over backwards to try to get that for patients, providers, because they were fairly clear that that's what they wanted. So this is an example, just spin through this quickly. This is an example of one trial run we've done, what it would look like with 150 hospices, although right now we're looking at data for this measure for about 25 hospices, I think, which amounts to about 500,000 patients. But walking through this, you can imagine this O209, the comfortable dying measure, proportion of patients whose pain is adequately controlled at 48 hours. You could imagine, and this is based on data from one hospice, that hospice's score doesn't look good, 65% compared to a mean of 76%. But we can also help that hospice unpack those results, and we can help that hospice to figure out that it's not necessarily, although that might be some of it, it's not necessarily that they're doing worse in terms of pain management, but they have the deck stacked against them because they have a larger proportion of patients with cancer who have lower scores. So even though overall, sort of an interesting statistical trick, right? Even though overall their pain management scores aren't necessarily worse, if you look across strata, cancer, heart failure, Parkinson's, because cancer patients' scores are so low, you can imagine if this hospice, as they did, took care of much greater population of cancer patients compared to other hospices, their scores are going to be lower. Not because it's something they're doing differently, right? But because they have the deck stacked against them, because they have a large proportion of patients who are predisposed not to do well on that score. That doesn't mean they couldn't do better, and it certainly doesn't mean that they shouldn't work really hard to develop special pain protocols for patients with cancer, because that's the opportunity to improve. So I'm not giving this hospice a pass, but it does help them, I think, to understand why their scores are so low and where they need to focus, and give them some guidance about how they could focus to improve. This is ultimately where we'd like to go, I think. As a researcher, as an academic, I love analyzing data. I love publishing papers. I've worked with enough hospice providers to know that they don't really like reading papers. And no matter where I publish papers, that's probably not going to influence practice. So we need to develop, and we are developing, other techniques to improve practice, like identifying champions at each hospice who look at the data that we produce, often long before it gets published. We help them to craft PowerPoint presentations that we share throughout the network. They do presentations in team meetings and in other settings to begin to get data from these papers back to providers, sometimes given publication lag, 6 to 9 months. sometimes even a year before a paper is published. I'd really, though, like to take the next step and look for other ways to get data back to providers. We heard loud and clear, this is the way I started the talk, and this is the way I'll end it. We heard loud and clear from providers, and from our CEOs, that we really want data that are usable. And I think we're getting better at getting those data back to providers, but we're not nearly there yet. Maybe it's decision support that's embedded in point-of-care software. That's what I would love to do. Maybe it's better education. Maybe there are other opportunities, and I'd love to talk offline with you about those sorts of other ideas, because that's really ultimately what makes a network like this successful. That's clearly what people wanted, and that's, I think, what we need to give them if we're going to keep this going. I'll stop with this quote because it's one of my favorites. William Gibson's a science fiction writer, and he says the future is here now. It's just not very evenly distributed, and that's kind of a background message I try to give all of our hospices as they're thinking about signing on to this network. I'm pretty sure that there are hospices in our network or that are planning on joining our network which know how to deliver care really, really well, and maybe, honestly, know how to deliver care in ways that beats whatever we think the current standard is now. But I don't know where those hospices are, and I don't know what they're doing. And so part of my goal, and honestly, if I'm totally honest with this group, as I have increasingly been, this isn't so much about decreasing variation. It's not so much about trying to get the best evidence out to hospices. A lot of what we're trying to do with Choice is to figure out what that evidence looked like, to figure out which hospices are doing really, really well on pain management, of avoiding hospitalizations or whatever, and to figure out what they're doing that makes them so effective, and then begin to disseminate that. Because I think some of the lessons come from us and some of the research that we do on our server back at the University of Pennsylvania, but I think some of the lessons come from the hospices. This is a bunch of 4 or 5 hospice nurses going out for a beer after work, talking about their problems, coming up with a new way to do things that turns out to be really effective. But we can't learn from that, we can't share it unless we can either eavesdrop on those conversations or unless we could look at their outcomes. And for me, as we start thinking about outcomes, that's probably the most important reason to do a lot of this work, not to promote data, but to figure out what the best practices look like and learn from those. So I stop there. Thanks.